Hello, hello. Welcome in to the Fetal Alcohol Spectrum Disorder webinar. We have a lot of folks in the waiting room, so it's going to take a minute or two to get everybody entered to virtually walk in. But I want to thank you so much for joining us. We're super excited about this presentation and also to bring Dr. Jasmine to you, who is the director of the Fetal Alcohol Spectrum Disorder Clinic at the Mind Institute here at UC Davis. She is an amazing presenter and a wealth of information. It looks like maybe we've got some people who we finally got everybody kind of coming in right now. So let me show you and remind you that September, oh, hopefully my screen is sharing properly. It's kind of not indicating that. Are you seeing the red shoes?
Yep.
Yes.
Okay, thank you. We decided to have this webinar in September because it is FASD Awareness Month. And wondering, did you know that FASD is one of the most common but often misunderstood neurodevelopmental conditions impacting children and families? And this month is all about shining a light on FASD and breaking down the stigma and sparking hope for youth and families who deserve understanding and support. So how can you do that? Well, today you're joining the webinar so that you can help spread the news and the information and share and support youth and families impacted by fetal alcohol spectrum disorder. And you can also rock your red shoes. Red shoes have become the symbol of FASD awareness. And so I absolutely bought a pair of red Converses myself, and I plan to wear it with my red lipstick so that when I hopefully draw some attention and I can speak about fetal alcohol spectrum disorder throughout the month and throughout the year as well. I would really like to introduce you to Dr. Jasmine. She is the developmental behavioral pediatrician, assistant clinical professor, and the director of the Fetal Alcohol Spectrum Disorder Clinic in the Department of Pediatrics at the Mind Institute at UC Davis. She's also an accomplished author, instructor, and presenter. We're going to ask, because this is such a large group attending the webinar, that you hold your questions until the end of the presentation. Alternatively, if you're like me and the ADHD might get to you and you'll forget your question, you can put it in the chat. I'll be grabbing them and we'll highlight them at the end during the Q&A portion of the webinar. Thank you so much. I am Tamara Trejos. I am with the RCFFP at UC Davis, and we're very proud to bring you the Fetal Alcohol Spectrum Disorder webinar and Dr. Jasmine.
Thank you very much, Tamara, for the kind introduction. And thank you everyone for being here. Good morning, and I am very excited to be here today and talk with everyone about fetal alcohol spectrum disorder today. Let's see. So I have no conflict of interest. Close. So before we start, we have a lot of participants today. So I would love to know like where everyone's are from. So we're gonna have a poll pop up. If you can answer like where you are from, then this will help us learn about you. I see most people come from California. I see other states too. If you can specify in the chat where you're from, then we can see that. Yeah, a lot of California. Yes. Okay. Yeah, I think this gives us a good idea. So 99% are from like California and maybe like 3 people or 1% are from other states. Ah, okay. All right. Then, oh, what? Okay. And I think if you still have the poll up, you may need to click X on the right upper corner to close out the poll. And who are you? Like, what do you do? Why are you interested in FASD today? So this will bring up another poll.
The other poll is in populating.
James, did you launch the poll?
Just a moment.
Okay, thank you.
All right, here we go.
A lot of social workers, mental health providers. Also, there's a lot of others, and a lot of chats coming in. As you nurse practitioner, post-adoption, wraparound, social services, service coordinator, juvenile court. It's running very fast. Health education assistant, LMFT, home visitor, wraparound services. Yeah, so we have a lot of people and we have some caregiver here too. Family specialists, human services student, clinical director of mental health clinic, parent educator, regional center service coordinator, facilitator wraparound, community developer. Yeah, we have a lot of different professionals joining and also caregiver. This is good. Thank you for sharing. All right. Okay, then now we're gonna move on. Yeah, so also, think about like what's your goal today? We're gonna be here together about like an hour and a half. What are you looking for in today's talk and what's your goal? If you can share in the chat, I'll be sharing my goal, what I was thinking, and then we can see at the end if we match your goal too. So our goal today, for me, I hope everyone will learn about the characteristic of children with fetal alcohol spectrum disorder, how to screen and assess, and how to support the patients and family. So some of you may have heard the term fetal alcohol spectrum disorder, FASD. Some may be more familiar with fetal alcohol syndrome or FAS. But what's the difference? Let's go back to the start from the history when we start to recognize the effect of alcohol in children. So in 1968, that's the first time when the negative effect of alcohol on developing fetus was described by Dr. Lemoyne and colleagues in France. A couple years later, in 1970 and 1972, Dr. Uland and colleagues in Washington also described the similar finding in the US. Dr. Jones and Smith describe a common pattern of congenital malformation in children exposed to alcohol in utero in 1973. And they coined the term fetal alcohol syndrome for the first time in 1973. Then, about 20 years later, the Institute of Medicine, or IOM, described the diagnostic criteria for fetal alcohol syndrome. It also described 3 other distinct diagnostic categories: partial fetal alcohol syndrome, alcohol-related neurodevelopmental disorder, or ARND, and alcohol-related birth defect, ARBD. So these are collected under the umbrella terms of fetal alcohol spectrum disorder, or FASD. FASD is not the clinical diagnosis. It is an umbrella term with other diagnostic categories under it. So you can see FAS is under FASD. In 2005, Dr. Jaime and colleagues published a paper to clarify the 1996 IOM criteria for FASD from a practical standpoint. And it was updated in 2005 and again in 2016. This is one of the diagnostic guideline that is commonly used in the US now, and this is the diagnostic criteria we use in our clinic. Looking at the Jaime criteria, the 6 main areas they look at are history of alcohol exposure prenatally, facial features, growth restriction, deficient brain growth, neurobehavioral impairment, and birth defect. We will talk more in details for each area later. Around the same time that the IOM criteria was developed, Dr. Ashley at University of Washington and the Washington State FAS Diagnostic and Prevention Network developed another diagnostic system called the 4-digit diagnostic code in 1997, which was then updated in 2004 and recently updated again last year in 2024. The 4-digit code has its own diagnostic categories, which is slightly different than the IOM or the Jaime criteria in terms of the terms they use for diagnosis. Some of the diagnostic categories in the 4-digit diagnostic code that is under FASD umbrella is fetal alcohol syndrome, static encephalopathy, alcohol exposed, and neurodevelopmental disorder, alcohol exposed. But they're looking at the same thing. They also look at facial features, growth, the development of the brain, and prenatal alcohol exposure history. In 2016, another team by Dr. Doi and Madsen published another diagnostic guideline focusing on the alcohol effect on the brain function, independent of any physical effect like facial features or growth restriction. The diagnostic term they use is neurobehavioral disorder associated with prenatal alcohol exposure, or NDPAE. So NDPAE is included in the appendix of the DSM-5 under conditions for further study. The DSM-5 provides detailed diagnostic criteria as shown here in the picture. In addition to a history of PAE, the DSM-5 criteria for NDPAE require impairment in 3 functional domains, so neurocognitive, self-regulations, and adaptive functioning. NDPAE is considered another term under the FASD umbrella. If we compare to the Jaime criteria, this is close to the alcohol-related neurodevelopmental disorder, or ARND, and the 4-digit code, it is close to static encephalopathy, alcohol exposed, and neurodevelopmental disorder, alcohol exposed. The DSM-5 criteria for NDPAE is commonly used by psychologists as it does not require medical physical exam, but it needs a confirmed history of prenatal alcohol exposure, which many times, sometimes is unknown. It's a challenge to get the history. Multiple guidelines and criteria have been developed. So these are the 3 most commonly used diagnostic guidelines in the US. There's also guideline like Canadian guideline, there's Australian guideline out there also. So even though each criteria here kind of have slightly different details on how they what they define on the diagnostic criteria for FASD, there are generally 5 diagnostic areas they look at. So the next part here, we're talking about like what are we looking at when we diagnosing FASD? So the 5 areas to focus on when diagnosing FASD are prenatal alcohol exposure history, growth restriction, facial features, brain structure abnormality, brain function abnormality. So the first area is prenatal alcohol exposure history. CDC report about 1 in 7 pregnant people in the US reported drinking alcohol, and about 1 in 20 pregnant people reported binge drinking in the past 30 days. So this is a lot than what I thought before I learned more from CDC. So in general, this criteria is made by self-report or report from reliable source with estimated dose or documented blood alcohol concentration level in medical record. This is challenging, like I said before, as a lot of time patients are in foster care or adoption, and the information may not be available. Also, this is an information that we will not get it unless we ask. And it is very important how we ask, if we ask in the right way. So we should ask with non-judgmental way to kind of make it part of the medical history. We may have information about baby being positive on testing for many substances, but it is very difficult to test for alcohol at birth as alcohol has very short half-life. So confirmed alcohol exposure is not required if all other criteria for FAS or partial FAS met and no confirmed no alcohol exposure. However, this information is very important because less than 10% of patients with FASD has facial features. And this information can help them meet the criteria for alcohol-related neurodevelopmental disorder or neurobehavioral disorder, prenatal alcohol exposed, without the facial features. The next part that we look at is the growth restriction. So we look at the height or weight at birth or at any point in childhood or even during pregnancy if they have in utero growth restriction history. Depends on the criteria, the definition may be different. The HIME criteria define growth restriction as less than 10 percentile. We should also use clinical judgment if this is explained by malnutrition or chronic illness alone or not. The third part is the facial features. So the 3 main facial features that all criteria look at is short palpable feature length, that's the length of the eyes, thin upper lips, and smooth philtrum, which is the curve above the lip as shown in the picture. The HIME criteria require at least 2 out of 3 features for the diagnosis. There are other congenital anomalies that can be seen in kids with FASD, but it is not part of the diagnostic criteria. So you might see a railroad track ear, the two-fold along together, as you've seen here. Epicanthal fold, which is here on the eyes, and the 5th digit clinodactyly, which means the bending of the 5th digit, and the ptosis of the eyelid here. You can also see the hockey stick on the palmar crease here, but again, it's not a diagnostic features. The last 2 areas are within the brain. So brain structure and brain function abnormalities. And it is actually the most important part because not every kid that exposed to alcohol will have FASD, but it is more important how that affects the brain and their function for daily life. So let's look a little at how alcohol actually affects the brain. You can see here that the brain cells and neurons start developing since the first week of pregnancy and throughout pregnancy. So even before anyone knows they are pregnant, right? That's very early. The fetal brain is extremely sensitive to alcohol. It affects the fetal brain on a cellular level, leading to a reversible structure and functional change in the brain. So the effect of alcohol exposure depends on timing, the level, the pattern of exposure, as well as the fetal genetic susceptibility and multiple characteristics of the birthing person, like age, nutrition, or genetics. As each baby has different sensitivity to alcohol, at this time, it is unknown what level or pattern of alcohol exposure can be considered safe. So the recommendation is abstinence from alcohol when trying to conceive and throughout pregnancy. So that means there is no safe amount of any type of alcohol at any time during pregnancy. So this slide shows area of brains that may be affected by the prenatal alcohol exposure. It might look a little bit like busy slide here, but it is showing that FASD is a global brain injury. Any part of the brain can be affected, and different kids can get affected in a different part of the brain. There's some study, the longitudinal study to age 17 years old have demonstrated that a typical patterns of brain maturation and differential relationships was seen between the developmental trajectory and cognitive function compared to control. So the concentration of neurotransmitter metabolites, which is the chemical in the brain of the with prenatally exposed, also appear to be different from the kids without the prenatal exposure. And functional imaging studies have identified significant differences in brain activation relating to working memory, learning, and inhibitory control in children and adolescents with FASD. So several studies have found relationships between the morphological differences and cognitive function, suggesting some clinical significance to the structural brain abnormalities. Following the prenatal alcohol exposure, the brain's developmental trajectory and its relationship to cognition are different than what is seen in typical development. So as a clinician, it is more important to know like how does the brain structure affect the function of the child. So the three main areas that may be affected are neurocognitive, self-regulation, and adaptive. So in different age from for neurocognitive, so in baby and toddler age, they may have cognitive delay or global developmental delay. As they grow to school age and adolescence, they may have low IQ, intellectual disability, and learning disability. For self-regulation, starting at very young age, they may have impaired stress reactivity and pain regulation, difficult to self-soothe or be soothed, and immature play skills. In older kids, then they may have inattention, hyperactivity, and impulsivity, impaired executive functioning, sleep disturbance, and sensory processing changes. For adaptive is one of the most common and concerning area. The baby may have growth or fine motor delay, poor feeding. As they get older, they also have auditory processing delay, speech and language delay, and poor memory. Then in adolescent year, they have impaired higher order language processing, impaired social pragmatic, memory deficit, and visual spatial deficit. You may think many of these issues are commonly seen in our patients with other diagnoses like autism spectrum disorder or ADHD. And that is true that some of the symptoms may be overlapping, but the underlying etiology is different. And that can affect the intervention and support we provide and how they actually respond to the intervention that we provide. So back to our diagnosing area again, the last two areas we were discussing are the brain structure abnormality and the brain function abnormality. So as we discussed how alcohol affects the brain, the diagnostic guideline then look at microcephaly, which is a small head circumference, which reflects the small brain size. Any abnormalities in size or shape of brain structure are also considered here. Although having the brain imaging might help for assessment, it is not recommended to get the brain imaging just for assessment unless there are other medical indications. Non-febrile seizure is also counted as it reflects the neurological abnormalities here. So for the brain function abnormality, depending on the clinical guideline used, diagnosis require significant impairment in at least one of these domains. Significant impairment being deficits of more than 1.5 or 2 standard deviation below the mean. So to summarize again, the 5 areas that we look at is first, the prenatal alcohol exposure history, which could be from self-report or reliable resource or documentation. Second is the growth restriction, looking at weight or height less than 10 percentile at birth or at any time of life. The third one is the facial features with the 3 main features: short palpable feature, which means short eyes, smooth philtrum, and thin upper lip. Brain structure, looking at microcephaly, abnormal brain imaging, and non-febrile seizure. Last one, brain function abnormality, so deficits in any area like cognitive, academic, adaptive, social skills, communication, memory, mood regulation, and executive function. So as we talk for a while, you may notice there are many challenges in diagnosing FASD. First, there are multiple guidelines with different diagnostic criteria and diagnostic terms. The required information requires multidisciplinary team for diagnosis, like to get the psychological assessment, education assessment, and also this is sensitive topic that may come with concerns of stigma from screening process to diagnosis and treatment. The stigma could be from different levels, from self-stigma, stigma by association, structural stigma, and public stigma. Even the public service announcement designed to raise awareness and help families and birthing people can reinforce the stigma. Using language like 100% preventable and describing the responsibility of the birthing person to be absent from alcohol, this ignores several crucial factors that play into substance use in pregnancy. Factors like inequity in access to reproductive education and care, how nutrition and environmental factors play into FASD. The fact that here in the US, nearly 50% of pregnancies are unintended, that substance and alcohol use disorders are not a choice and are heavily influenced by environment and mental health. So with the many diagnostic challenges and stigma, why do we have to give a diagnosis? Why not just treat the symptoms? So let's hear from this video. This is one of the videos from the CDC FASD series. And I think she gives a very good perspective. So let's watch together.
Lived experiences with fetal alcohol spectrum disorders. Annette.
My name is Annette Kunzman, and I'd like people to first and foremost know me as a mom. I have 2 young adults that are 31 and 20.
So checking, can you hear the video?
Yes.
Yes, we can.
Okay, thank you.
7, and both are on the FASD spectrum. I wanted to come here today to increase awareness and bring acceptance to the condition called FASD, fetal alcohol spectrum disorders, because the vast majority of people don't know anything about it. They've never heard of it. My husband and I adopted our two sons. The first one was an infant, and the second one 4 years later. What we were concerned about in adopting children was obviously, number one, not having much family history. We were concerned about drugs, drug exposure. And the one thing we didn't think about at all was the one legal drug that's available everywhere, and that's alcohol. Both as infants, we took them to the pediatricians, and they said, healthy, but, later on, things in their development weren't as typical. They didn't get a diagnosis until they were 14 and 18. So we had a lot of trials and errors trying to figure out what was going on with them. And then, of course, issues, particularly with my oldest son, happened when they start school. Our oldest son was very active, just very, very active. His play wasn't like some children, for example, with blocks, putting blocks together. He would just scatter them all over. There was nothing methodical about stacking them. Now I can look back and see there were sensory issues to tags on the neck or the toes, the seams on the toes. When I went to put sunscreen on him, it was like I was putting acid on his arms, And then in school, I was trying to get some answers from the teachers, and they said, oh, don't worry about it. 4th grade, I got the school to do a whole assessment of our oldest son. They wanted to just say it's IQ, and that just didn't sit right with me because he was so bright in so many other ways. And so I do remember making an appointment with the school psychologist to try to go get some help, wondering, what I might do to help him. And her first question was, so how are things at home? How are things between you and your husband? So from the school's perspective, we were doing things wrong as parents. And of course, I was questioning myself because I was a working mom. I wasn't there all the time. And so we were sent to many parenting classes, and we failed them all. Of course, over time, you learn that traditional parenting doesn't work when children have been exposed to alcohol. Going to the medical community, they didn't have much information. They didn't have much guidance. It was really all looking at physical. And that's when I quit my career. I gave up my career because I needed to focus on what was going on. I suspected that there was alcohol exposure. I denied it. I was in denial, but the seed was planted and I pulled it out. I finally found a doctor who really gets the medication, because it's tricky with people who have been prenatally exposed to alcohol. They don't process medicine the same way. So it's lots of trial and error. I think my oldest son must have tried 15 different medicines. So we're now in Colorado, and what we did is we found a property where the basement was unfinished, and we built 2 apartments. They each have their own apartment. They were both involved with how it was set up. My oldest has a gaming room that's off his sitting room where he has a big screen TV. And the younger one, we set up a workshop for him. So he's got a 3D printer now, and he's going to be painting these little figures, making these figures and painting them. He's also a very accomplished pastry chef. So that's how we're situated. We said this is for now. You don't have to live here forever, but for now, this is time being. And so then I just have to pay one bill. They don't have to worry about their rent. They don't have to worry about utilities. I think it's not that they can't do it. It's just where to start, how to, that they just get so overwhelmed by the idea of it, they just shut down. But the one great strength of our kids that have been infected is that they get up every day. I can't imagine how strong and brave they are. They are. One condition that my oldest son in particular has is we called it perseveration. He would just get an idea and he can't let it go. He's a dog with a bone. He just perseverate on an idea. But the flip of that is it's perseverance. They persevere, and I think that's one of their greatest strengths.
For more information, visit cdc.gov/FASD.
Yeah. So, again, that's the video from the CDC FASD website, and you can find more videos there from there will be like perspective from caregivers like adoptive parents, foster parents, or even biological parents, and also the patients themselves too. So if you are concerned about the labeling and stigma and hesitated to bring this up to parents, these videos will help you hear from them directly, and it help us learn like how diagnosis actually help them move forward. So like what the video said, the diagnosis help the child and parents have better understanding of the child. While the behaviors may be the same, the underlying cause of behavior is different, and which then affect how we can support and help the child. The diagnosis will provide access to support networks, evidence-based treatment, and intervention. The accurate diagnosis is also important that it can help improve the quality of and funding for research and implementation of interventions and prevention. So we are talking about FASD. How important is it? What's the prevalence of FASD? How common is it? So let's see, what do you think? James, can you bring up the poll for the prevalence? Please, thank you. There's a lot of response. Yeah, I see a lot of response from 1 in 500, 1 in 50. Yeah, I can tell you it is more common than you think. Okay. Okay, so you can see, so it looks like most people think it's kind of 1 in 500, 1 in 50. We also get like 1 in 20 and 1 in 30. Yeah, and some 1 in 1,000 here. Yeah. So, okay. Yeah. So, like I said, FASD is actually more common than you think. CDC reported up to 1 in 20 US school-age children may have FASD. Depends on the study. It is varied 1 to 5%. So for fetal alcohol syndrome, CDC report 1 in 1,000 live birth, and in other study, it could be 6 or 9 to 1,000 school-age children. So FAS is a lot less common than FASD. So FASD is a broader spectrum, remember. So when we look at the prevalence of FASD, CDC reported estimated 1 to 5%. And looking at this number, this is more common than autism. Most recent report from CDC, autism prevalence was 1 in 36 children. So now we know why it is important to give diagnosis, and it is very common. So who should be screened for prenatal alcohol exposure? Everyone. So this should be a screening question as part of the birth history. Just like how we ask any medical problems during pregnancy, or if mother was taking any medication during pregnancy. Even though everyone should be screened, children in foster care or adoption are at higher risk for FASD and should all be screened. So how do we screen? Remember, this is an information that we will not have it unless we ask. And it is very important on how we ask. If I ask you, did you drink alcohol during pregnancy? What would your answer be? No, right? So we should be mindful that this is a sensitive topic and we should ask in a non-judgmental way as part of the birth history. The American Academy of Pediatrics has recommendation and sample of questions on how to ask questions and how do we approach this topic. So this is some of the example of the questions. How can we start the questions with the families? So now that we have, let's say we have baby J here. Now that we have baby J medical history, let's talk about pregnancy. This will help me get to know baby J and your family better. How far along were you before you found out that you were pregnant with baby J? Did you have any medical conditions or concerns during pregnancy? Did you experience any anxiety or depression during pregnancy? Now I am going to move on to a series of questions that I ask all women about their use of tobacco, alcohol, prescription, and non-prescription drugs during pregnancy. Before you know you were pregnant, how much alcohol did you drink? And so if the mother shows concern that she drank before she knew she was pregnant, reassure her that she's not alone in doing so, and that awareness allow for monitoring, moving forward, and intervention if needed. Then after you found out you were pregnant, how much alcohol did you drink? Were there any prescription or non-prescription drugs that you took while pregnant? If yes, can you tell me the name of the drugs and how often you took them? Has there been a time when you smoked cigarette? During the pregnancy, how often did you smoke any cigarette? Is this your first pregnancy? If no, then ask tell me about your other pregnancies. And then just ask about other neonatal delivery and neonatal information that has not been discussed before. So, and then at the end, is there anything else that you might want to share or tell me about your pregnancy with baby J? So for me, I found that mother is usually answering this question kind of straightforward when we ask them in a neutral way and non-judgmental way. So remember, I really like this code here. And I think it really helps shift a lot of the perspective on FASD and why baby was exposed to alcohol. So no mother drinks because she wants to hurt her baby. There's so many factors that baby can be exposed to alcohol, like we discussed earlier. So what's next? So if you screen positive for prenatal alcohol exposure, then what's next? So we should discuss the possible effect of prenatal alcohol exposure and FASD with the parent. Refer to pediatrician or specialist for further assessment. Who can diagnose or assess for FASD? Some pediatricians are specialized and familiar and able to diagnose FASD too. Some pediatricians may refer to specialists, and some specialists that can assess for FASD are developmental behavioral pediatrician, geneticists, psychiatrists, and psychologists. I would recommend to start from pediatrician as the primary care, and then they can decide the next step. Provide support and resource with understanding of FASD. So here, in Sacramento at UC Davis Mind Institute, we do have the FASD clinic we call Pediatric Evaluation for Alcohol-Related Syndrome Clinic. This is a clinic that we do FASD diagnosis and assessment. We are seeing kids 2 to 12 years old with our insurance, and all we need the referral from pediatricians and other supporting document like IEP evaluation report or the regional center evaluation report, any past medical history record or birth record, that would all be helpful to us. In Southern California, there's also clinic that doing FASD diagnosis. The two clinics that I know is the Violence Intervention Program, or the VIP clinic, and the Rady Children's Hospital. So I put the link and the QR code here for California resource from FASD United. They list other places in California that also assess for FASD. There's also resource for other states on FASD United website too, and I put the link here also on with the QR code. So now we know how to screen and how to assess for diagnosis. The next part, we will talk about the treatment, and the two main part of the treatment gonna be first the non-pharmacological or psychosocial interventions, and the second part is the pharmacologic intervention. So for non-pharmacological intervention, it is the first line treatment. So these are some example of the intervention program that was studied in children with FASD. Project Good Buddies focus on building peer relationships. The ALERT program used sensory integration activities to build self-regulation skills. Math interactive learning experience, or MY, targets math problems and behavioral challenges that interfere with learning. Family Moving Forward combines positive behavioral support, motivational interviewing, and cognitive behavioral treatment. So this all sounds very good, but they all have very limited availability. None of them are available in Northern California. So, but we do have the Family Moving Forward available in Southern California with the Violence Intervention Program, or VIP clinic, in LA County. At VIP Clinic, they also have another program called Triumph Through the Challenge of FASD, which is a 6-week group parenting class that increases caregivers' knowledge and understanding of how prenatal alcohol exposure has impacted their child and how to support their child. The team required parents to complete the Triumph class before applying for the Family Moving Forward program. The Triumph course is virtual and they accept Medi-Cal patients. I recommend my patients to register this course with them too. Then at the end of this course, they will offer Family Moving Forward program to parents. This is then more individualized program. So with the limited resource and intervention available throughout the state and nation, so what do we do? What else can we do to help the family? So first, back to basic. Healthy lifestyle modification, right? So first, eating. Because of the difference in sensory processing, children with FASD may have restricted food options. With many of them already have growth restriction, we want to make sure they are eating and getting adequate nutrition and continue to grow. Exercising so they can stay healthy, and sleep. An hour of physical activity during the day will help promote sleep, which is very important as it can affect the daytime behaviors. Kids with FASD tend to have sleep problems and may need melatonin or other medication to help. Then we should utilize the available behavioral intervention we have, but using it with FASD awareness. So some of the intervention we usually recommend parents now is PCIT, PC Care, or Triple P. Many times parents come into the clinic with negative view of their child's behaviors as they are exhausted and don't know what else to do. These therapies focus on positive parenting strategies and create a positive relationship between parents and the child. I always tell parents that it is very important to share the diagnosis with the therapist, as this intervention has not been studied in children with FASD. So some of the strategies may need to be modified. Some strategies, such as consequences, may not work for children with FASD, as their behavioral difficulties are often from brain-based deficits, not behavioral-based problem alone. So it is very important for parents to understand FASD, as they are with patients the most, and maybe the one that brought FASD to teacher or the therapist. As a social worker or provider working with children with FASD, this resource can help you learn how to support them too. We talk about the triumph through the challenge of FASD, which is a 6-week group parenting. Parents have to register on the website, and I put the QR code here again for more information. This is only for California, and they only accept Medi-Cal. Triumph through the challenge, Triumph Today video series on FASD is a playlist of 16 videos helping parents understand FASD and how to support the child. This is free and they can watch on their own convenience. It's a playlist on YouTube. The next one is 8 Magic Keys. I really like the 8 Magic Keys. 8 Magic Key is a 2-page handout that gives the 8 main strategies how we can support the child with FASD to set them up for success. I'm gonna say actually this gonna work for any kid, but especially for kids with FASD, they really need this. Some of the strategies are having structure and routine. Use concrete terms and be specific when giving direction. Try to keep it short and sweet as they get overwhelmed easily. Sometimes they forget what they just learned and may need reteaching and will continue to need supervision. On the second page of the handout, they provide description of each strategies, and I put the QR code here for the handout. So this is the handout that maybe the parents can also share with the teacher and whoever work with the kids. The last one, Understanding FASD, a comprehensive guide for pre-K to 8 educators. This is a more comprehensive one, like 100-page PDF file. But this really helps guide the teacher and school to understand FASD and how to support the child in the classroom. These are 2 books that I recommend my patients to read. The first one is Trying Differently Rather Than Harder. This book really shifts the ideas of understanding the behavioral difficulties in children with FASD. So it's shifting the perspective from they don't want to do it to they can't do it. Because then it's not because they don't want to do things, but maybe they're lacking some skill and they can't do it. And because when we can do something, sometimes it's hard to just say like, sorry, I can't, I need help. Kids will just have behavioral difficulties, has tantrums or meltdown, and then that get viewed as defiant or just they know and they just don't want to do things. So like I said, children with FASD, many times their behavioral difficulties are not just the behavioral problems alone, but it's also the brain-based deficits that they may have. The other one is the Essential FASD Support, and this is also provide a lot of guide on the support, how family can support the child. Moving to the second part of the treatment, pharmacological intervention. So there is no specific medication for FASD. We really just treat the symptoms and the comorbidity. There's very limited available data and results are mixed on how children with FASD respond to medication. But we know that they're at high risk for polypharmacy needing more than one medication, and also high risk for the compounding side effects. So many times kids with FASD also have comorbidities like ADHD, and they will need ADHD medications. Every time trying on medications, I always recommend and discuss with parents on the plan on how we do the medication. It's always going to be a trial to see how kids respond, and we adjust based on that. So other recommendation is it is important to identify other comorbidity and treat them along with FASD, like I mentioned, like ADHD, anxiety, those all need to be treated too. Having FASD does not rule out genetic disorder. So some genetic disorder may have the same facial features or overlapping with FASD. So with facial features or other indication for genetic testing like intellectual disability, I would still recommend to do genetic testing or referral to the genetic doctor. Early intervention is very important to help promote the development in early age, and school IEP can help support them in the class to help them learn. So in addition to the resource we have discussed, Mind the Gap is a team at UC Davis Mind Institute that create and collect resources for family and put them in a digital binder. And FASD is one of the resource categories they have. This is open for providers and family for free. So I put the QR code to the link here. They're not only talking about FASD, they're also resource about like how to navigate the system, like how to request an IEP, and resource for California. These are parent support group, and so they have a monthly parent support group that parents kind of meet together and learning from each other or supporting each other. FASD Network of Northern California, FASD Network of Southern California, and Parents Helping Parents. They kind of have parent support group on a different day, so you can explore and see what is best work for you. And again, this is all free, and I put the link to their website here on with the QR code. FASD United is a nationwide resource for FASD. They have Family Navigator program that can help identify resource needed for each state, so not only California. So that's the website and the QR code. Every year annually, they also host a conference in Seattle, and I really recommend if you want to learn more about FASD, this is a very good conference. Every other year, the conference will involve the families, adolescents, and adults with FASD, and we learn about their perspective. Because we are talking about FASD, we should include them who also have the direct experience in, and we learn directly from them. And so the next conference is going to be next April in Seattle. And the information will be on the FASD United website. FASD United also launched the Language and Stigma Guide on their website to help us learn more about the appropriate language we use and the stigma that can come with the FASD concerns. So this is the link to the guide. I learned a lot from the guide, and I changed some of the wording or things that I use to help decrease some of the stigma. So take home message. I hope you learn that FASD is more common than you think. Screen for prenatal alcohol exposure as part of your birth history. Facial features are found less than 10% of children with FASD, so don't use it to rule out FASD. Even they don't have facial features, they might still have FASD. When traditional behavioral intervention doesn't work with the families and rethink about the behavioral concerns and try different approach. And FASD is a lifelong condition, and lifelong support is usually needed. And again, this month, September, is the FASD Awareness Month, and I'm so glad we get to talk about FASD today. And you may learn more about FASD through the AAP FASD quiz here. AAP and CDC also have a lot of information on FASD on their website too. Thank you very much for your attention today, and I am happy to take any questions, or if you want to share any of your experience about working with families or children with FASD, I'm happy.
Thank you so much, Dr. Jasmine. That was incredible. So wealth of information. Folks, in the chat, we have dropped quite a few times a resource guide that contains all the resources that Dr. Jasmine shared. We also have dropped the slide deck. And Dr. Jasmine, we have quite a few questions that I've been collecting along the way. So if you're ready, I will start asking.
Thank you. Yes.
Okay, so the first one says, how do we know the difference between FASD and autism when no physical features are present?
That's a very good question. I even asked myself too, right? How do we separate them? We can actually. There is no clear line between like FASD and autism. There's something that's overlapping and something that's not. So they both kind of have their own criteria on assessment. They can co-occur just like how ADHD and autism can co-occur. This is the same thing. So we just look at the information and go through the criteria. Children with autism, many times so both the children with autism and FASD, they both struggle with social, but it's kind of like in a different aspect. Autism kids sometimes they don't have that social reciprocity. They cannot do like a back and forth. They're lacking skill for social communications, and they may be missing some of the social cues. And I know autism is a spectrum, but most of the time, sometimes they're not really like seeking the social interactions. There are some on the spectrum that actually trying to seek the interaction and struggle too. But most of the time, children with autism, they may not be really like seeking for social interaction, but children with FASD, they're actually seeking more like social interactions and wanting to make friends, wanting to be with other, trying to please other. And that, but because they don't understand the complex of the social relationships, sometimes they don't understand the social cues that, oh, they're actually bullying me, and they can be used and tricked to do wrong things. And they just want to be part of the society. So that's some of the difference that I see. But again, both of them are spectrums, and they just have like some overlapping symptoms. We still go through the DSM-5 criteria for autism. If they meet the criteria for autism, I diagnose autism along with FASD too.
Thank you. This question is asking about, are other organs impacted internally? So is there medical research or study around the strength of ocular muscles or malformation of internal organs, or a fetal alcohol related heart murmur indicating a cardiology impact in utero? So it sounds like they're kind of wondering the physical implications.
You mean, sorry, I missed the first part of the questions. Do we need a referral for cardiology? Is that?
I think what they're asking is there any study or information around how internal organs such as the heart or the muscles are impacted as in people who have FASD?
Mm-hmm. So we still need a lot more studies, but there are studies more on like physical disability now with children with FASD, because like you see, all the organs kind of develop throughout pregnancy, and every cell can get affected from alcohol expose. And so any organ system can get affected. Yeah, so they at higher risk, but we do need more studies on what specific physical concerns that we should be like screening. We don't have a clear like screening guideline now, like if we diagnose FASD, what else should we be screening for? I think for now it's just like screening, just like a regular screening, make sure they're doing healthy and just like other people.
Another question is, does fetal alcohol spectrum disorder trigger other genetic or spontaneous abnormalities that may mimic fetal alcohol spectrum disorder?
Like I mentioned, because diagnosing FASD does not rule out genetic disorder. So if there is a sign or indication for genetic testing, I still recommend doing a genetic testing. A lot of my patients, especially if they have like facial features, I still recommend doing a genetic testing.
The next question is there any research on how FASD directly impacts interoception abilities, which are essential for self-regulation?
Can you repeat that again?
Is there any research on how FASD impacts interoception abilities?
Yeah. So yeah, in interoception, you mean like self-regulation, right? How, yeah. So yes, so a lot of times children with FASD have difficulty with self-regulation, mood regulations, because the brain get effect on like the prefrontal and can affect on that part, and that's very common. Did that answer the question?
I think maybe we've got some thank yous in the chat. There's a question a couple of times asking about, are there some written resources for teens to communicate with the teen, a way that would help them understand their diagnosis?
Yeah, there's a lot of resource online now that can help children themselves, adolescents kind of learn about the diagnosis and how the diagnosis affect them, so they understand themselves. And that's the goal of the diagnosis, right? So they can understand themselves and family can understand them too, and people around. There's a resource online. I can add that to my resource list.
Thank you. There's been a couple, I'm going to summarize because there's been several questions about FASD and regional center eligibility, with a mixed experience of being denied or accepted, particularly under the 5th category. Is there anything that you could speak to about regional center and FASD?
Yeah, so right now, FASD is not the eligibility, is not one of the eligibility category for the regional center services after 3. So it really depends on the functions or what other comorbidities they have. Then the regional center will determine the eligibility. So it is based on like the cognitive or the adaptive functions. They have like their functional, like function categories that they're looking at, like communication, self-help skill, things like that. So what I can say right now is that having the diagnosis of FASD alone does not qualify you for the eligibility for the regional center. But if you have a lot of functional deficits, the family may contact like the regional center and then they can determine. I still trying to find out about like the 5th category, what is the specific criteria they use for the 5th category, but they told me it's a team decision, so I don't have a clear answer to that. Or if anyone from the regional center is here to share, I would like to hear from them too. But this is what I know so far. I still recommend, like when the family and kids struggle, I still recommend them to reach out to the regional center, and then, they can, at least they can try. And then the regional center will let us know. Sometimes at young age, it's kind of hard because like adaptive function, at young age, we're not expecting a lot, and maybe there's a deficit right here, and that's not enough for the regional center to provide eligibility. But then moving forward, as they grow up, we are expecting more. The expectation is higher, and if they're not making the progress, the gap might get bigger later. So sometimes they get denied at young age, but if they struggle more at older age, like in teenagers, then maybe we can reapply. So that's what I told family too. Even we get denied this time, maybe in the future we can reapply.
Thank you. Thank you for clarifying. That was a lot of good information to share. Thank you. This question is asking, do you have any knowledge about research related to music helping to grow brain connections, improve neurofeedback, and the biobehavioral catch up.
Yeah. So I think, just like how the Ed Magic's key kind of said, we just have to reteaching and supporting them. The skill or the strategies that we use to teach them should be focusing on like the skill building to help support them. Sometimes it's the direction, how we give the directions to teach them, and it's just reteaching and practicing, go over things and more supervision to help them so they can function. But so it doesn't mean that they can't learn, but we have to understand that their difficulties are not like just behaviors, but it's more about like their brain deficit, and they will need more teaching and more learning and more practicing.
I think that this next question is related to what you're speaking to. It's asking about the brain plasticity and old research, with the old research indicating that prenatal alcohol impairs plasticity. Do you know if that is still considered factual, or do we have better information?
I think the plasticity still like get impact, and I don't have a better information. I can look up and see more.
Thank you. Sorry, I'm scrolling through more regional center questions that I combined. That's like really kind of a hot topic for folks. Oh, this was asked a couple of times. Does alcohol consumption by the male partner affect the sperm and then subsequently contribute to fetal alcohol spectrum disorder?
I think there start to be new study about the alcohol consumption in the father that might affect the kid. So, but the study is still in mouse, like a basic science study. But there starts to be an ideas and study on that can may have effect also. We just there's a group that do the study just present at the Seattle conference last year. Yeah, so that will be a study of the future.
Thank you. This question is asking, do the key signs and symptoms of FASD change through developmental stages, say between infancy, childhood, and adolescence?
Mm-hmm. Yeah, so the criteria can be different also, like, what we look at in young age and then after. So like the Jaime criteria, less than 3 years old, for the neurobehavioral impairment part, we look at different things. So we look at the developmental delays in different domains. Moving to the more than 3 years old, then we're looking at the cognitive and the behavioral impairment. So we're looking at in a different details because at different age, we have different expectations and how kids are doing.
Do we have any studies or information on the long-term outcomes for children that have been diagnosed with FASD?
Yeah, I think there's study on that. And so we know that this is a lifelong diagnosis that kids continue to need support. You can hear from the video that caregivers still like have to provide support for their kids who's already like adult individuals with FASD. There but we know that if we understand and provide support, then they can function, but they might still need supervision in a different part, because some other things that we do as an adult is such an abstract concept, and it's hard for individuals with FASD to kind of navigate or organize that, like organizing on time, financial organizations, and things like that. So they still need kind of like support throughout their life for that. How much support they will need, it really different, because every individuals with FASD are all different.
This question has been asked a couple of different ways too, but I think the underlying is there an amount of alcohol that maybe is safe to use, or type of alcohol that is safe to use, or is there any studies about it's more likely to cause FASD used during different trimesters?
Mhm. So like we kind of talked in the beginning that there is no, because every baby has different sensitivity to alcohol. We never know if they're gonna be highly sensitive or they're gonna have low sensitive to alcohol. So then that means there is no safe amount of any type of alcohol at any time during pregnancy. That's the recommendation at this time. And the best practice, like the best recommendation, ideal practice gonna be trying to stop drinking when you try to pregnant, when you plan for that, right? So but as we all know that we don't know we're pregnant. A lot of the pregnancy are unplanned, like almost half of the pregnancy in the US are unplanned. So that can happen. But to answer that, no, there is no safe amount of any type of alcohol at any time during pregnancy. We do know that the pattern of drinking, like binge drinking one time, is more likely to have effect on the fetus more than the small drinking. But it doesn't mean small drinking is safe, but the binge drinking is more dangerous.
Thank you. This question is asking, I believe, for clarification to understand the diagnosis of FASD. When it says, I'm sorry, I'm butchering this one. It's I'm just going to read it because it probably makes more sense that way. Clarification on understanding that to be diagnosed with FASD, you had to meet 3 criteria, including dysmorphic facial features, growth deficiency, etc. And if all 3 criteria were not present, diagnosis would then be PFAS.
So under the umbrella of FASD, there's different categories, right? So like fetal alcohol syndromes mean you have all the features. Fetal alcohol syndrome means you have the facial features, you have the growth restriction history, you have microcephaly, which is small head, and you have neurobehavioral impairment. So you have all the features with or without the confirmed prenatal alcohol exposure history, as long as it's not a denied, like no alcohol exposure, then that's the diagnosis for FAS or fetal alcohol syndrome. Partial fetal alcohol syndromes means you so the criteria for the HIME criteria is gonna depend on if you have the confirmed prenatal alcohol exposure. So if you have prenatal alcohol exposure history, then maybe you have facial features, but not the growth restriction and not microcephaly, but you do need the neurobehavioral impairment, then that you meet the criteria for partial fetal alcohol syndrome. But if you don't have the confirmed prenatal alcohol exposure history, we will need a little bit more information, right? So that means you have maybe facial features, growth restriction, or microcephaly, just one of them, but not all of them. And neurobehavioral impairment. That's partial fetal alcohol syndrome. But even though if you don't have like facial features, growth restriction, or microcephaly or small head, but you have confirmed prenatal alcohol exposure and neurobehavioral impairment, that you still meet the criteria for alcohol-related neurodevelopmental disorder. So the physical features is not always needed for the diagnosis. It really depends on what other pieces we have. And that's also like why we have another diagnostic guideline from the DSM-5 for NDPAE, neurobehavioral disorder, prenatal alcohol exposure. That one is more focusing on the prenatal alcohol exposure history and the function of the brain.
Thank you so much. And the last question that we have is, what are the best ways to educate communities about preventing FASD?
For preventing, it will be more to at least like no safe amount of any type of alcohol during pregnancy. That will be the first step, right? Once you know you're pregnant, then no alcohol. That will be the first step, because you would think that is known everywhere, but I still have patients that come in and telling me that, oh, the doctor tell them that, well, it's okay to drink during the third trimester. So the rumor like this is still out there. So we have to kind of correct and make sure the right information get out, that there is no safe amount of any type of alcohol at any time during pregnancy, even the third trimester, because the brain continues to develop throughout pregnancy and even after birth, and they can get affect anytime. The next step, like for like prevention, like policy is like giving education about like birth control, right? Or planned pregnancy. So if we have more planned pregnancy, then we can work on with the knowledge of like not having alcohol during pregnancy, then that will help prevent FASD.
We had one more question pop up in the chat, asking about ABA as an effective treatment or intervention for children with FASD, particularly those under age 5. What are your thoughts?
So ABA is an intense behavioral therapy, and with FASD alone, it's kind of mixed result, and I don't think we have a good study like any other like intervention that I mentioned before, like PC care, PCAT. We don't have a good study on children with FASD, and we do need more study. If my patient only have FASD, ABA will not be the intervention I recommend to, because one is that I don't think insurance will cover that either, but it is more kind of intensive behavioral therapy that sometimes, many times, ABA is about consequences, like how they teach kids how to do things or not do things. So the approach might be kind of different, like difficult, and maybe make it more stressful for family and children with FASD. But if my patients have FASD and autism, now it really depends on which one kind of show more to me. If I see a lot of like autism behaviors or symptoms, I do still refer them for ABA therapy. But again, with the awareness of like telling the parents that it will be very important to let the therapist know that the kid also have FASD, and maybe some strategies might need to be modified, because when things getting too stressed or not working, then let's think about this again, and can we shift it in a different way?
Thank you so much, Dr. Jasmine. This has been amazing. I have been riveted on the edge of my seat the entire time. So I want to say thank you, thank you, thank you. And before you guys all click out and leave, let me also make you aware that Dr. Catherine Page has been in the audience as well, and she is also an extremely wonderful and gifted educator and one of the foremost authorities on FASD. Her next class is in May, and unfortunately, our second half of the year is not posted yet. So I'm sending you right now where you can grab a link to where you can watch for that class. They fill up fast. We allow 80 people, and her class consistently is like double and triple in size and has a wait list. So I would start checking in November and December to see that class posted at that link. Also, if you could give us a few moments more to fill out a poll, James, go ahead and launch that, please, because your feedback helps us bring you the content that you need, that you like, and hopefully in a manner that suits you, as well as it's great feedback for the folks that pay the bills so that we can continue to provide this education to you free. So please, please, please take a moment to fill out. I believe it's only like 9 questions on the poll. If you are interested in asking for a letter of attendance, I'm going to drop that link here for you as well. Let me grab that. There we go. Sorry, computer got a little slow. you can submit through this online, very short form, a request for a letter of attendance at this webinar today. Also, this will be posted in about a week, along with all of the goodies that got dropped for you along the way. And you will find that posted here, which I just also dropped in the chat. Those who are asking for a certificate, I will redrop again the link of where you will go online and fill out that request. Great question. This is a webinar. It is a webinar that is recorded and will be posted for you in about a week on our 0 to 5 classes webpage, along with the resource guide and a PDF of the slide deck. And we hope.
I'm
Sorry.
so sorry. I was just gonna ask, what would be the appropriate subject area to identify on the link you sent?
Subject area.
Yeah, it's complex care, center for excellence, wraparound, system of care, peer partner, qualified individual. Just
Oh, that's interesting because I'm not seeing that on my side. I don't see that. I would say system of care. I would choose system of care.
okay, thank you.
Mm-hmm.
Early childhood 0 to 5 is also an option for that section.
Is it,
I don't
then
know if
that's
that
perfect.
was.
Yes, thank you.
So sorry, I must have missed it, but for the certificate, do we have to complete anything, or will you guys be sending that via email? How does this work?
I'll drop the link to where you'll go online and fill out the request for a letter of attendance.
Can you remind me again what the title of the webinar is?
Yes, it's just FASD, fetal alcohol spectrum disorder.
Okay, thank you.
Sure.
Which one do we pick for the subcategory again?
Early childhood, 0 to 5.
Well, it says, oh, okay, I got it. Thank you.
Sure. Thank you, everybody.
Thank you.
Thank you, Doctor.
Thank you all so much.
Yes, thank you. It was a great webinar. Thank you very much.